Bismillah ar-Rahman ar-Rahim. The subject uh, of this lecture is the orbit. The orbit is the bony surroundings of the eye and the ocular adnexa. It is having a medial wall, lateral wall, roof, and floor. The function of the orbit is to protect the globe. Attachment also, it gives attachment to the extraocular muscles and ligaments, stabilizing the ocular movement, and it has the apex in which there is a foramen for the passage of the optic nerve. There is superior and inferior orbital foramina for they pass the nerves and the blood vessels and veins to the orbit. What are the clinical features of orbital disease? Proptosis, enophthalmos, eyelid signs and conjunctival changes, pain, diplopia, defective vision. Proptosis, the proptosis or exophthalmos is the first clinical feature we see in orbital diseases. It is protrusion of the eye, usually caused by a space occupying lesion behind the globe. We can measure proptosis of the globe by an instrument called exophthalmometer. A difference between both eyes of 3 millimeter, more than 3 millimeter, is significant. Various other features will give a clue to the pathological process causing the proptosis. It may be inflammatory, it may be tumor, it may be multiple causes can cause proptosis. Proptosis can be due to swelling or a space occupying lesion inside the muscle cone, and this will give axial proptosis, or outside the muscle cone, and this will push the globe in the opposite direction. So clinical feature of proptosis, intraconal lesions will produce axial proptosis, forward axial proptosis, and for example, optic nerve sheath meningioma. Number two, extraconal lesion outside the muscle cone, which is the forerecti. This will produce displacement of the globe in the opposite direction of the swelling. Also, sometimes proptosis may occur transiently due to increased cephalic vein pressure, as in straining or Valsalva maneuver, and this is may be seen in cases of orbital varix. The speed and onset of proptosis may give us a clue of the etiology. So, slowly progressing proptosis may be seen in benign tumor. Rapid onset with inflammatory signs may be seen in orbital cellulitis. Malignant tumors may have a rapid deterioration and rapid development of proptosis. Carotid cavernous fistula proptosis with engorgement of the vessels on the surface of the conjunctiva. The presence of pain may suggest infection, as in orbital cellulitis. The second orbital sign that we may see in ophthalmos, which is backward displacement of the globe. Usually this may follow orbital fracture, where the orbital contents will be displaced through the fracture in the walls of the orbit. For example, if there is fracture in the floor of the orbit, the content of the orbit will go through to the maxillary sinus, and the globe will be retracted in the orbit and producing an ophthalmos. It may be sometimes we may face pseudo enophthalmos, as in Horner syndrome, but this is not enophthalmos. It is the appearance as if there is retraction of the globe or enophthalmos, but this is due to narrowing of the palpebral fissure, which is due to mild ptosis that occurs in Horner syndrome. Pain occurs in acute inflammatory conditions and in rapidly progressive malignant tumors in the orbit. Eyelid and conjunctival changes occur in orbital cellulitis, preseptal cellulitis, and in carotid cavernous fistula. Diplopia may occur as in this thyroid eye disease and myositis, where there is involvement of one of the extraocular muscles. So there is fibrosis, limitation of motility in specific directions of gaze, and development of diplopia. Also, diplopia may occur due to involvement of the nerves passing to the extraocular muscles in the orbit, as sixth nerve palsy, for example, or any other nerve palsy, resulting in diplopia in the direction of action of this muscle. Visual acuity affection may occur with orbital diseases, as for example in cases of proptosis, exposure keratitis may occur, and this will result in diminution of vision. Optic nerve involvement due to compression of the optic nerve may occur in orbital compressive lesions and inflammatory lesion. Disorders of the macula or distortion of the macula may occur due to a space occupying lesion pushing the globe or compressing the globe from the back, resulting in distortion of the macula, which is present on the near the posterior pole of the globe. What are the investigations that we use in orbital diseases? We use CT scan and MRI to localize any lesion, to see the extraocular muscles, to see the orbital content and the walls of the orbit. Differential diagnosis of orbital diseases, we have to see all the contents of the orbit and all the diseases that may occur related to these contents. So we have orbital diseases may include disorders of the extraocular muscles, infective disorders, vascular disorders, and orbital tumors. Disorders of the extraocular muscle, as this thyroid eye disease, involvement of the extraocular muscles in this thyroid eye disease, and development of proptosis also, and development of proptosis due to involvement of the orbital tissue with infiltration of glucosaminoglycans and inflammatory cells. Number 2, ocular myositis also may occur. Rhabdomyosarcoma, which is a malignant tumor occurring in the extraocular muscles in children, may produce proptosis in these cases. This is a proptosis that is occurring in a case of hyperthyroidism, so it is thyroid-related proptosis. Fee restriction of ocular motility in this thyroid eye disease due to fibrosis of one of the extraocular muscles. So here there is defective elevation of the left eye due to fibrosis of the inferior rectus. Here there is defective depression of the left eye. Here there is defective abduction, and here there is defective adduction. The second group of diseases, orbital diseases, infective disorders. We have the orbital cellulitis. It is a serious condition that may cause blindness and may cause death even due to spread to the brain and development of brain infection or brain abscess. Infection in orbital cellulitis usually arises from the adjacent sinuses, especially the ethmoidal sinus, which is adjacent to the medial wall, with a very fine puppellaceous thin bony lamina between the orbit and the ethmoidal sinuses. The commonest causative organism, Haemophilus influenzae. The patient will have painful eye, periorbital inflammation and swelling. Very important sign is reduced ocular motility. Also there is conjunctival injection, possibly visual loss due to compression of the optic nerve, systemic illness, and pyrexia. We may have a relative afferent pupillary defect due to damage to the optic nerve. Swelling fillets, swelling of proptosis, limited ocular motility are very important signs. CT scan and MRI is very important to diagnose. Also the cause and the source from the sinuses, and diagnose if there is subperiosteal abscess. And this, because this may need drainage, intravenous antibiotics, and we should monitor the optic nerve function. We should monitor the visual acuity, color vision, relative afferent pupillary defect, to avoid optic nerve compression. Orbital decompression can be done with the help of our colleagues in ENT subspecialty. Preseptal cellulitis, it resembles orbital cellulitis, but here the inflammation is limited to the anterior to the orbital septum. That's to say, is not involving the orbital tissue. So when you open the eyelids, you will see the globe free. There is no proptosis. There is proper vision and ocular motility, and it is not like the orbital cellulitis. It's not the same emergency. Orbital mucocele, and this is a chronic inflammatory swelling that results from accumulation of secretion of any of the paranasal sinuses with when the natural drainage of the sinus is blocked, and the protrusion of this swelling through the orbit will result in development of proptosis and swelling, cystic swelling behind the globe, which is called orbital mucocele, and the treatment requires surgical excision. This is a case of orbital cellulitis, and here it shows the sinus, ethmoidal sinus involvement in this case. Preseptal cellulitis, if you elevate the eyelid, you will see the orbit, you will see the globe freely mobile. Mucocele from the frontal sinus. Inflammatory diseases also may occur as a chronic inflammatory diseases. For example, sarcoidosis and orbital pseudotumor, in which the inflammation is and the proptosis is gradual, and usually there are systemic signs of the cause as sarcoidosis, and sometimes lymphoma, orbital pseudotumor, and so examination of the orbital tissue, and sometimes we may need biopsy of the orbital tissue to diagnose these lesions. Vascular abnormalities that may affect the orbit. Fistula may develop between the cavernous sinus and the carotid artery, and this is called the carotid cavernous fistula. So the sinus pressure will become arterialized with increased intravascular high pressure in the sinus. So the pressure will be reflected on the superior and inferior ophthalmic veins, which drain the orbital tissue to drain from the orbit to the cavernous sinus. This will result in engorgement of the veins in the orbit, proptosis, engorgement of the extraocular muscle with reduced ocular motility. Also, there is increased intraocular pressure. And these patients will need intervention with embolization of the fistula between the artery and the cavernous sinus. This is a direct carotid cavernous fistula. Sometimes we may also hear bruit over the orbit. We put a stethoscope and we hear the bruit, which is the voice due to this fistula. Conjunctival engorgement. Last vascular problem that we may see in orbital diseases, orbital varix, and we said it is proptosis that occurs on Valsalva maneuver due to congestion and engorgement of the orbital of an orbital varix. تمام? And this is when intermittent proptosis occurs when the venous pressure rises in this orbital varix. Capillary hemangioma is another vascular problem that occur usually in infants. It occurs in the orbit and the skin around the lids, and usually it undergoes resolution by the 5th year of life. Treatment indicated if there is if the size is big or there is occlusion of the visual axes due to the ptosis that develops in the eyelids, and for the risk of development of amblyopia. Local injection of steroids may reduce the size of the lesion. Sometimes also beta blockers are given to help in regression of these capillary hemangioma. An infant with capillary hemangioma involving the upper lid of the left eye. Capillary hemangioma, also the right upper lid and the forehead. The next subject is orbital tumors, and they may produce signs of orbital disease. Orbital tumor may develop from any of the contents of the orbit, as the lacrimal glands, the optic nerve gliomas, meningiomas from the meninges surrounding the optic nerve, rhabdomyosarcoma from the muscle, metastasis from other systemic cancers as neuroblastoma in children, breast, lung, prostate, and GIT cancers in adults. Usually we do CT scan and MRI, biopsy and biopsy for the diagnosis, and sometimes we may resolve to excision of these masses to diagnose the condition. Optic nerve glioma, proptosis, axial proptosis, optic nerve atrophy. It may be associated with neurofibromatosis. This is a CT scan of a secondary tumor in the left orbit. Meningiomas of the optic nerve are rare and difficult to excise. Some may benefit from radiotherapy. Sometimes they may extend to the middle cranial fossa or may spread from the middle cranial fossa. Lymphomas may present as widespread disease or may be localized to the orbit. The widespread disease is treated with chemotherapy, but if it is localized to the orbit, it is treated with localized radiotherapy. Rhabdomyosarcoma occurs in children as an orbital tumor, rapidly growing tumor of the striated muscles. It is a malignant tumor. Chemotherapy is effective if the disease is localized to the orbit. Sometimes you may need radiotherapy. Excenteration also may occur in severe cases of rhabdomyosarcoma. Dermoid cysts, these are continued growth of the ectodermal tissue beneath the surface of the skin. It may occur in the medial or the lateral aspect of the superior orbit, and we call it internal angular dermoid cyst and external angular dermoid cyst. The treatment is excision for cosmetic reasons, usually, it is also a type of benign swellings. This is an external angular dermoid cyst, and this is internal angular dermoid cyst in a child. This is an external angular dermoid cyst. Okay.